Good morning, everybody, and welcome to the California League of Cities Health Benefits Marketplace webinar on retiree healthcare solutions. So first off, we're going to deal with a couple of housekeeping items. All attendees are in listen-only mode. If you have a question, if you look to the right-hand side of your screen, you should see a question box. If you type your questions in the question box, at the end of the presentation, we will endeavor to answer as many questions as possible. If we do not get to all the questions, we will reach out to you individually with answers to the questions. Thank you.
Good morning, everybody. This is Chris McKenzie, Executive Director of the League of California Cities. I'm glad to be with you today. You just heard from Barry Hare, who's the consultant for the League, and he's going to be speaking with you today, and he is then going to be joined by John Andrews with Willis Towers Watson. The health benefits marketplace, we think, is a powerful technology solution that makes the delivery of health benefits easier and more cost-effective for you and your entire workforce. We have been working with a number of internal committees and our board of directors over the last 18 months to evaluate options for solving the challenges you and your employees and retirees are facing, and is in the health insurance arena. And as part of that, we ran a highly competitive request for proposal process. We chose Connecture as our partner to run the active employee solution, and we had a webinar about those services yesterday. And then we also chose Willis Towers Watson as our partner for the pre-65 and Medicare eligible retiree solution. Accord was chosen as our partner for the ACA compliance and reporting, and Wellwright was chosen as a partner for employee wellness programs.
So good morning, this is Barry from Diversified Benefit Strategies, and so I've been working now with Chris and the League leadership. We're on this platform for about 18 months. The League determined that there are a range of issues that are facing, challenges facing cities in California in terms of management of health care, both for active employees and retirees. Health Benefits Marketplace has been designed to provide tools and solutions for addressing this range of problems that are faced by cities. Primarily, we're looking at solutions related to ballooning OPEB liabilities, which is a significant problem faced by numerous cities in California. Obviously, we needed a solution that would involve coverage for both active and retired employees. The Affordable Care Act has increased reporting requirements on cities, and meeting those requirements has presented a challenge. So that was an area that we endeavored to find solutions for. Additionally, lack of flexibility in terms of plan design through CalPERS, and just in general, managing flexibility of plan design was an issue that was of paramount importance. So the solution that we've come up with is highly flexible. And we've also tried to integrate solutions that can help bend the healthcare cost curve. And additionally, we've got a solution overall where we're going to be able to incorporate new tools and techniques for managing healthcare costs going forward. So these are the challenges that we've attempted to address. Now, yesterday, as Chris mentioned, we had a webinar that dealt with the active employee platform. And so on the active employee platform, we went through the types of medical and ancillary coverages, the structure around benefits, how they're paid for on the platform, and that webinar is available to be reviewed on the website. Today, we're going to be focusing on retiree issues. Both pre-65 retirees and Medicare eligible retirees, and a range of solutions that can be implemented to help address the cost of these benefits and help in reducing OPEB liability. So at this point, I'd like to introduce John Andrews from Willis Towers Watson, who will introduce the platform that we have chosen. to help manage these costs.
Thank you, Barry. Good morning, everyone. My name is John Andrews. I'd like to lead you through a discussion about the retiree solution within the health benefits marketplace, and also describe for you how we suggest evaluating that solution as well. So just as a reminder, the plans that are used for the retirees in this solution are from the individual market, and that's both for the pre-65 retirees and for the Medicare eligible or post-65 retirees. And this encompasses the medical, dental, vision, and prescription drug benefits. What we've summarized, when you think about the challenges that we've heard from cities on what they are trying to solve for as it relates to their benefits portfolio in general, when we focus just on retiree healthcare, rising cost seems to be a simple theme to use to capture those challenges. So what we're prepared to solve for in those challenges are these three main areas. So the rising cost and associated OPEB liability caused by the increasing trend to push healthcare costs upward, and the GASB accounting rules revisions that are creating more pressure for each of you to solve for that liability to offer those future benefits. We also understand that there's a desire from retirees seeking the ability to personalize their benefits. Many times we'll see retirees leave a plan for more cost-effective options, and if they do, leaving the group plan leaves that plan with a less favorable risk pool. Usually your better risk is leaving your plan if that's occurring. Medicare retirees primarily focus on the prescription drug plan. That's likely not news to you as the focus on what their primary benefit value is in this arena for the Medicare folks. And then, how do you honor your promise to these retirees, basically? How can you continue to provide a subsidy and competitive benefits to those folks in the future? So our discussion this afternoon will mainly review these four key areas. I want to give you an overview of what the retiree exchange model looks like, how it operates, and give you a sense of what your role is in that model. Talk about the communication plan and the change management that occurs for retirees to learn about this, understand it, and take action, recognizing that many of those retirees have never had to take action regarding their benefits in the past. I'd like to review the implementation steps with you so you can have an understanding of what work effort is involved for yourselves and for your team members as you design and implement the solution. And then lastly, I'd like to close with an approach that we recommend on how you evaluate this as an alternative to your current group plan. And there's a defined actuarial model that we recommend be utilized in this capacity, and we'll review that as well. So first, let's start with the model. So I've put together a structure here to try to capture the primary components of what's involved in the exchange model when you think about your role as the employer and the retirees' activities that are presented to you currently and where their needs should be solved in the future. So this construct gives you a sense of where the employer's role is. Once this is implemented, and this is post-implementation is the view I'm showing you. Once this is implemented, the interaction with retirees directly becomes fairly limited because the exchange becomes the face to the retiree to serve them with their questions, with advice, with enrollment support, and so forth. So a key role in this model that the exchange brings is the human side of this, the benefit advisor and the customer service representative that face the retirees directly and work with them through the evolution of their enrollment, through the needs for advocacy and post-enrollment. So keep in mind the roles that the exchange brings, and those individuals are all based in the U.S. They operate from a service center. There are 3 locations in the U.S. where those individuals reside. The major city they're close to, and they're actually located in suburbs, but we're outside of Salt Lake City, outside of Dallas, Texas, and outside of Phoenix, Arizona. So it's all onshore. There's no dialect or communication challenges to understand how these folks are communicating over the phone, and that's the model here. So it's a customer service-based telephonic model serving those retirees. The employer's role becomes primarily focused on the design of your subsidy and managing your relationship to the exchange. And so many times there is a efficiency gain on the administrative side of managing your group plans offered to retirees after having moved to the exchange, because your roles evolve and focus more on managing your partner as opposed to managing retiree activities one-on-one. The right side of this graphic, I've included the plans that are offered, and you can group these plans together. The colored boxes to the right, we're identifying Medigap, the Part D prescription drug, Medicare Advantage. Those plans are all tailored for the Medicare eligible retirees. So those are supplement plans that go alongside core Medicare. The dental and vision plans are offered both for Medicare or pre-65 retirees. And then for the pre-65 folks, the bottom half of this graphic identifies the public marketplace and private plans that are offered by carriers but not filed on the public marketplace. So we facilitate access to those individual plans as well. You might hear them referred to as the metals benefit value of platinum, gold, silver, and bronze. That's a benefit value tied to those plans. We are facilitating the movement out of your group plan into those individual plans as well. So this can be a holistic solution for both pre-65 and Medicare retirees, but it does not have to include both. You can move each of those populations independently, and you basically split the family record and the eligibility data in order to do that. Individual coverage purchased on the exchange costs the same as it does as if that consumer went directly to the carrier. And that's an important note in terms of how you evaluate the price of those plans. And the price of the individual plans vary based upon geography, age, and gender. And that's how those plans are offered. A key aspect of this design is that when the employer makes a transition to the exchange and eliminates their existing group plan, that creates a unique opportunity that CMS governs, and it's referred to as a special enrollment period. And that special enrollment period allows all of those retirees to enroll in these plans in the individual market on a guarantee issue basis with no limitations, no obstacles, and no underwriting applied. And there's a defined period of time of prior to that loss of coverage that they can enroll and receive guarantee issue coverage. So when I get to the communication plan, it's important to know that there is a window of time that we're trying to take advantage of in order to have those folks understand their benefits and take action to move on. A little bit more about the carriers. The carriers that are attached to the exchange are very familiar brands to you all. So these are national carriers supplemented with regional carriers as well. And the reason we have a mix of the two is because many times Medicare Advantage plans are very competitive and offered by regional carriers based upon their networks. And we have contracted with those carriers as well to make sure that the choice available to retirees is a meaningful amount of choice. We're listing here that we have over 100 relationships with carriers, and that's true when we think about the national footprint of zip codes. But the menu of choice for a retiree in a zip code location is generally around 15 to 20 different plans, and our process to advise them through the benefit advisor helps that retiree really reduce that supply of plans down to around 2 to 3 plans that really fit their personal situation best, and the focus and discussion is really on 2 or 3 plans. So it's great to have a large footprint of carriers, but you don't want that to become overwhelming and daunting for the retiree as they navigate the process. The other part of this graphic I'll point out, you'll see that this is designed with puzzle pieces going around the square. Those are aspects of our technology that we've evolved over the last 10 years of providing this solution, where we can keep track of our applications as we push those to the carriers and make sure that we can constantly provide an update on status to the retirees on where they stand with progress towards ultimately receiving their ID card. And I'm sure you're all aware that receipt of the ID card is a major milestone in terms of the retiree's view of confirming their benefit. The last piece I'd like to talk about on the overall structure is the subsidy. So in this model, the employer subsidy is redefined or newly defined as a defined contribution value, a monetary value that's administered in a health reimbursement account. So that HRA is attached to the structure of the exchange, and there are some conveniences that are offered to the retiree, having it embedded within the overall structure so that their reimbursements occur on a predictable schedule and on a timely schedule. And we've developed something we refer to as auto reimbursement that allows for the retiree to set up a program of reimbursement process that once they've enrolled in a plan, and that carrier bills them for that plan directly, so they get an invoice directly from the carrier in this model. The carrier sends us a file that identifies the macro list of individuals that have paid their premium, and we trigger a reimbursement directly back to the retiree in an automatic fashion. So once they set this up during their enrollment, they're literally not having to touch the reimbursement process as long as that plan is the same plan they stay enrolled in. And if they change that plan, then we can modify that auto reimbursement mechanism. The employer, if you focus on the left side of this graphic, the employer has all abilities to design what the HRA reimburses, including who's eligible, what expenses are reimbursed, what the allocation amount is, and the allocation frequency, and whether it's a year-end forfeiture or a rollover. So we basically serve as your advisor to give you all the elements of what you can design, giving you guidance and prevalence on what's most commonly done and what's most popular in terms of overall service to the retiree. But ultimately, that's the ERISA plan going forward. And as you manage your plan going forward, it now becomes the HRA in this model. So the retirees are interacting with us and leveraging their dollars, and the claims going against the HRA are primarily premiums for their plan they've enrolled. If you design the HRA such that the eligible expenses include all IRS code 213D eligible expenses, which basically means premium plus out-of-pocket expenses, then they could submit claims directly for any deductible copays and so forth that they've encountered as well, if they have a balance available beyond what their premium reimbursement is. Okay, so with that structure in mind, I'd like to talk to you about the communication plan and how this is organized, because we've mastered this not only with the message we know we need to convey to the retiree, but also based upon feedback we receive directly from retirees on how they've interpreted that information and their ability to absorb information at certain intervals of the process. So it's not only what you say, but when you say it, in terms of managing through this change management event. So when you think about the program in general, we look at this in 4 main components: announce, educate, enroll, and support. So this is pretty straightforward, but if you think about the announce phase, this is the employer announcement letter that comes directly from you as the employer that basically includes information such as, dear retiree, we have made a decision to alter our current plan of benefits. The new plan will be based upon a subsidy valued at X dollars. You will be working with the health benefits marketplace in order to find your replacement coverage. Here's the process to reach out to them. And there are certain components of what you should say, not only to convey that this event is occurring, but the timing of that announcement also triggers the date for which you as the employer can begin to recognize the reduction on the liability for that plan design based upon what you define going forward. So 2 key dates there. You're telling the retiree of what's going on, but you're also making that public announcement so that as an employer you can begin to recognize the value of this new benefit design. When phase 2 starts, that's when they start to receive the communication materials that we have developed to supplement once that announcement news has been received. So literally 2 days later at their mailbox with similar branding, they will receive materials that provides them education on what they should do next. The education includes an overview of what the plans represent, what they cover, how to go about evaluating those plans, and primarily who to call for help, which in this instance will be the health benefits marketplace. We prefer that those retirees call us early and start to learn about the process and allow us the opportunity to provide them education and information. And then another key aspect that we've learned is that retirees really like to schedule an appointment. So during that first call, we want to provide them information and answer all their questions, but also confirm a scheduled appointment during the open enrollment season so that they know when to call us back and when to be prepared with one of their adult children or a loved one or an advisor that helps them with benefits so they can arrange for that schedule and be fully prepared. So that's once we reach the enrollment phase, now that's, they've reached out to us to that scheduled appointment, they're talking to the benefit advisor, and for those that did not take action, we have some additional communication tools to make sure that we're reaching out to them. We use a campaign that we call No Retiree Left Behind, and that means we actually are calling and tracking every individual on the eligibility file to understand what the disposition status is so that we can make sure they're given the opportunity to take action. So things like reminder postcards, and ultimately a certified letter for someone that just does not respond. Maybe it's because we had a bad address, maybe it's because they were traveling overseas, maybe they have a caregiver that is the primary person that acts for them. And ultimately we find those things out later in the season once we have not heard from those folks. Actually many times by getting advice from you on how you've been able to reach these folks over the last few years for when you've had to do similar communications. So once enrollment is complete, then they receive a kit for how to get to their subsidy, the HRA kit. That gives them information on how to file a claim, how to set up auto reimbursement, and how to leverage those subsidy dollars. That information is timed after enrollment, so they're not concerned about that ahead of when they need to make their plan selection. And we've learned over the years that that is the proper sequence to not confuse the retirees with too much information about things they cannot yet take action for. So I'll give you an example. You don't want to communicate the process to leverage the HRA in November when the HRA truly becomes effective in January. We've learned that that can create some anxiety for retirees where they cannot yet take action. So that's a good example of where timing matters about how this campaign works. And then once everything is live and we've made the enrollments complete, then we move into phase 4, and that's the support mechanism, and that's at lifetime advocacy for the retirees. So if they have a question about an explanation of benefit from a carrier, how to file a claim, they want to reevaluate their benefits, they want to make sure their doc is in the network, all of those calls in an advocacy fashion all are steered towards the health benefits marketplace, and we are supporting them thereafter. So as long as they're enrolled in a plan, they have support from us to help them with leveraging and using that plan. Part of the beauty in this model as well is because of our relationships with those carriers and the size of the enrollment population that we have with those carriers, we have really deep leverage with those folks in order to resolve issues. So much like yourselves, when you have in your self-funded plans the ability to make a call to your carrier and resolve any kind of service issue with quite a bit of speed, we have that same ability with our carrier relationships working on your behalf for that individual within the exchange. On the bottom side of this image, I'm showing you some representative samples of what these communication pieces look like. So they're small, but you can see the cover page of the Getting Started guide on the left and the yellow branding. Picture of the web access. So all of these tools and processes are available to the retirees to go online if they prefer. You'll find that retirees use the web primarily to do their research, and then they prefer to have a conversation with an individual in order to make their enrollment. That's the behaviors that we've seen. So we'll see many times upwards of 20, 30, sometimes as much as 40% utilization for the discovery research aspects. And if you're talking about a pre-65 population, you might see that be a little bit higher. But then after that, they really become more comfortable talking to the person one-on-one. The enrollment guide image is an example of what they use to learn about the plans itself, and it provides the phone numbers and contact information in order to reach us. And then there's examples of a newsletter and postcard, which are really an eye test for you because it's really small. But we keep in contact with folks with a newsletter twice a year as well, because it's appropriate for retirees to continue to evaluate their benefits each year, but the primary focus is on their prescription drug plan. So year to year, we see about 10% of all retirees will reach out to us to explore what their options are. About half of those make a change on their prescription drug plan because their prescriptions may have changed during the year, and they can find a more cost-effective plan, and they have the ability to make that change on a yearly basis during the open enrollment season. Okay, so with the communication steps in mind, I'd like to now focus on the implementation steps that are required for you to work with the Health Benefits Marketplace to set up the retiree exchange solution. So I've put together a graphic here that gives you a sense of the timing and the steps involved. The overall time frame is about 5 to 7 months, and it can be a little bit longer if necessary, if that's a desire from the employer. But generally it's about 7 months, which is what I'm portraying here. And when we account for 7 months, that includes the enrollment season after we go live and start communicating with folks directly to make their plan choice, which typically is we try to manage that to be between 60 and 90 days. So a big portion of this time frame overall is the actual enrollment season. But if you look on the left-hand side on the planning and requirements phase, and we've coded these so you can see where we're working together. So the green is the employer and Willis Towers Watson working together in design and implementation and plan documentation, requirements documentation type activities. The blue is identified as employer direct responsibilities, and then purple is Willis Towers Watson responsibilities directly. So in the first phases of implementation, we're focused on the eligibility data requirements. What information do we need about the retiree population in order to present them the communication materials and then qualify them properly for plans that they are personally eligible for. The communication strategy, how you want to message this change. Is this about greater value for the retiree? Is this about cost savings overall? Is it a blend of the two measures? All of those variables are different for each employer based upon your own objectives about why you pursue this kind of solution, and we help you work out what that strategy would reflect. Retiree planning meetings, we actually have found that alongside the communication plan, it's a good practice to organize live meetings where the retirees can come to a physical location, listen to the process for about 30 to 40 minutes, and then are provided the opportunity to ask questions. And it's facilitated by a One Exchange ambassador that understands the full spectrum of how this enrollment process should work. So it becomes more real, more tangible, more trustworthy to the retiree when they have the opportunity to participate in those town hall style meetings where they can come together. And then the last thing we include there is Benefit View. This is a portal that we've developed that gives you full access online to the status on our progress during the enrollment season. So if you think about that eligibility file that includes 200 names or whatever the population count is, you can see on a minute-by-minute basis what the status is for everyone that's eligible for that benefit. Have they reached out to us? Have we spoken to them? Do they have an appointment? Have they completed their enrollment? And that's giving us guidance on how to make sure that we've heard back from everyone in that No Retiree Left Behind campaign. The blue activities occur about month 3 in the process, and this is primarily focused on the eligibility file because either yourselves or your benefit administrator are managing that data today. So we work with you directly or your administrator to define how that eligibility data needs to be organized and sent to us so that we can load it in our systems to account for the HRA value for each individual and the basic demographic information about those individuals so we can contact them and present them the proper plans based on their home residence. And then we actually ask you to provide us some cultural training within our service center. So you may have a certain style and approach on how you've traditionally supported these retirees in the past. They may have had the luxury of walking into your office and speaking to you face-to-face. So we need to understand that, so we incorporate that into our service center culture, and we phase out and service and treat those retirees as close to what you've offered them in the past as we feasibly can, obviously over the phone. And that's an important step in the process as well. Month 4 is typically when the announcement occurs, and then the collateral for the communication material starts to commence, the enrollment guide, and that's when the retiree meetings are actually scheduled. And then once enrollment season begins, I'm starting in the purple shading now, that's when we primarily take control, and we're phasing out to the retirees directly and completing their enrollments and making sure that they contact us. After this is implemented, I wanted to give you a sense of what the responsibilities look like for the HR team in the group plan model that you're operating today versus what it would be in the future using the exchange model. So this is a simple summary of what some of those activities are, and these should look familiar to you. On the left-hand side, you're generally managing all of these activities and operating your group plan. You have carrier negotiations and renewals, formulary development as part of your plan design. If you're filing for the RDS subsidy reimbursement, you have that application process, open enrollment planning. For self-funded plans, claims appeals, your overall communication, HIPAA compliance, 5500s, SPDs, and so on. In the new model for the exchange, the main point on here is row number 3, where you're monitoring the exchange for the handling of all activities. So you're leveraging the exchange to now be the focal point for retirees interaction, but you now are the final appeal for the HRA. You're responsible for creating and distributing an HRA SPD, and you're responsible for sending us the eligibility data. So this evolves over time. This doesn't happen overnight. Retirees that have been accustomed to walking into your office don't immediately just call us, and we know that, but that transition will occur where this will become the focal point of where your activities will reside in the exchange model. And we're going to provide some opportunity for questions about this a little later in the webinar as well, and I suspect you may have some questions about this particular piece. So what I'd next like to talk about is the financial analysis. So we have learned over the years that there is an approach that employers have learned and basically need to use in order to evaluate this solution to, number one, determine, is this a viable alternative to what I offer today? And if so, how do I design in this model going forward to meet either promises, bargained agreements, or expectations that have been set in the past with this retiree population? So the way we've summarized this is that the examination should include an understanding of these primary aspects: optimal use of all channels for delivery of health benefits to retirees, and the primary channel evaluated in this analysis is the individual marketplace for plans. The magnitude of your retiree medical liability, and is that a driver to change and the necessity for change? What plan availability is there from the market in terms of plan supply for your location and the locations of your retirees? Sharing of the new value between the employer and the retiree. So if this model identifies that there is a significant value to be gained, do you pass all of that new value on to the retiree in the design of the HRA, or do you share some of that as the employer and offer that value over a period of time? You have all of the control over that. And then in the individual market, are you fully leveraging all the federal subsidies that are out there, primarily for pre-65 retirees, but indirectly through the carriers in the Medicare market? Are you leveraging those as well? And the RDS changes are a good example of how that operates for Medicare folks. So the objectives of the examination should include an evaluation of the individual product market as an alternative to your current group plan, both on the financial impact to the retiree, the administrative and financial impact to the employer, and the quantity and quality of the individual plans for supply and the availability for all those retiree locations. Most employers seek a subsidy design with a reasonable win-win outcome for both the retiree and the employer, meaning that you're sharing in the new value. With the new design in mind for the HRA, the defined contribution value, you then model the impact to the liability to determine what OPEB relief you can accomplish, and then ultimately you define the future subsidy with all those variables in mind. So I'd like to give you a view of what an example would look like. And this is a simplistic example, and it's not the full package, but it kind of gives you a sense of what we're looking for. And this particular example is a Medicare example. So in the table above, I'm showing you a comparison of what the current plan value, current group plan value would be in comparison to 4 primary and most popular plans from the individual market. And this evaluation is utilization data in order to determine the estimate for the retiree cost of at point of care or out-of-pocket expenses. So this is an evaluation that includes the cost of the plan for premium, the out-of-pocket expense that they would incur at various utilization patterns, and the overall impact to them for value. And so we do a comparison. Think of it as an equation where on the left-hand side of the equation is the current group plan and its overall value compared to what-if scenarios in the individual market offering a future subsidy design. And if you can see in this particular example, the subsidy design for this employer was roughly $2,661 per year. In the future, the new model is $1,500 a year. So that's an employer savings, yet still achieving a favorable outcome for the retiree. I won't go through all the numbers, but that's an example of what we typically see as an outcome. And then the bottom half of this example is how you evaluate supply. So for major metropolitan areas, we identify, and this is a top 5 location summary, we identify the quantity of your eligible population in that location and then identify the quantity of supply for those corresponding plans, either for Medicare or pre-65, so that we can make sure that there's an adequate amount of supply within a reasonable cost range. So the analysis will include basically what we refer to as a footprint analysis to help you evaluate from that view as well. In order to complete this analysis, we need data. And it's not data that you typically have to put a lot of effort into finding. Most of this is data that you're routinely working with in the management of your current group plans. But I'll just review them quickly. It's the census data that would include zip code, gender, age, and enrolled plan of your retiree population. We do not need any PHI information and prefer not to receive that. So we need just the basic demographic content. We need to understand information about your current plan, its design value, and the cost of that plan, ideally showing us the sharing between employer cost and participant cost so that we can identify what those opportunities are for the retiree in the future. If you're filing for RDS reimbursement in the prescription drug plan for your Medicare folks, we'd like to know the value of that. And we'd like to know of your current plan as it supplements Medicare and how it is supplementing it, because that's a big determining factor on the value of benefits that are offered by that group plan as it supplements core Medicare. We're happy to complete this analysis on your behalf. There's no cost in doing this other than your time, obviously, to gather the information. And we can typically complete that analysis within 2 weeks using our actuarial team. So this is an actuarial credentialed and peer-reviewed result that we provide back, and then we review this with you directly so that you have the opportunity to ask questions and potentially use this model in the future to look at different subsidy values or different designs that you may want to pursue ultimately in this new retiree exchange solution for either the Medicare and or the pre-65 retirees. So that concludes my review of the solution. Barry, I think we'd like to take a pause here and open it up for questions if we have any.
Yes, so if you do have any questions, as I mentioned at the beginning of the broadcast, there is a question box to the right-hand side. Please feel free to ask John any questions. And just to start off, I have a question I wanted to ask you, John. Could you please describe a little bit of the demographic trends that are driving why this solution works? What's going on in the individual market relative to the group market, please?
Sure, happy to do that. And I'll tell you, there are several variables that contribute to the why on why employers are pursuing this. But the overwhelming top reason I see this is because of the price point of the plans in the individual market compared to what the cost point is for group plans. And let me explain that a little bit more. An employer's population, even if you're one of the largest cities in California, your population size does not compare to the size of the participants that are already in the individual market. So let's give you an example for Medicare. There's roughly 40 million American lives that are covered by core Medicare today. About 7 or 8 million lives are in a supplement plan that's offered by their employer in the group setting. So roughly 32, 33 million lives are in the individual marketplace supplementing core Medicare, and that population is huge. And with the current dynamic of baby boomers aging into this Medicare space, those new entrants, obviously they're on a relative basis, they're younger new entrants. So the carriers are very competitive to seek out these new participants in their plans, and it translates to more cost-effective price points for those benefits. So it's kind of ironic and against the grain of what maybe you've always learned from the basics of underwriting, where a group plan in the law of large numbers should outperform any individual plan, and that's just not the case within the issue environment with Medicare and the marketplace now for pre-65, mainly because of the competitive nature of those carriers, the subsidies that are available in that marketplace to the same carriers that are no longer available, or at least they're reduced to the employers, and prescription drug is the main area I'm thinking about there. And just the overall price point of anti-selection and newer entrants coming in. So, Barry, I think price leverage, pricing arbitrage is really the key factor of there's just a better deal in the individual market. And until the exchange mechanism was really devised, an employer did not have an organized way in order to get your retirees to those individual plans without just sending them out on their own.
Okay, thank you, John. We do have a few questions coming in, and two of them are somewhat related, although slightly different. And the first question is, do you have to offer both active employee and retiree medical coverage through the marketplace? And along that line, the second question that's related is, does the One Exchange run through the Connecture platform? And for those of you that are not familiar with the Connecture platform, that is the active employee side of the marketplace.
So this is Barry. So there is no connection between, there's no requirement that you utilize the health benefits marketplace for both your active employees and your retirees. Again, I emphasized at the beginning, we've designed the health benefit marketplace to have maximum flexibility for public agencies. So it is basically a menu, and you choose the solution that is best going to meet your needs. If it was both, that's great, one or the other. And again, also, there's no connection between the funding levels between the active or the retiree side as well. So, and then specifically the question about the Connecture. So we have two technology platforms. One specifically designed to help provide benefits on the active employee side, and that is provided by Connecture. And then John's company, Willis Towers Watson, is providing the solution for retirees.
Yeah, and Barry, I would say keep in mind as well the difference in active and retiree benefits as we've presented them to you so far. The retiree benefits are primarily seeking individual products, and the active is built on a group plan basis. And so there are CMS requirements and licensure requirements in order to interact with an individual retiree and present them an individual plan. And that really drives most of the difference in why the process is different, the web technology is different, and the actual person speaking to the retiree versus an active is different. And it comes down to licensure and compliance with CMS, honestly.
Barry, could you cover the branding of the platform as it relates to active employees and retirees, whether it is one portal that you go through or whether there are two separate portals?
Yeah, so if a city decided to utilize both solutions, there would be a single point of entry for your employees and retirees branded to your city. They would select which area was appropriate to the individual, and the individual is then pushed to the appropriate portal. So there's a single branding, single point of entry. Obviously, because we have two vendors, once the person identifies themselves as either being an active employee or a retiree, there would be pushed to the correct vendor's platform.
Okay. A question about cost. What is the cost to the employer participating in this exchange?
John, you want to talk about like the HRAs, because that's really
sure. It's a great question, and I'm glad you asked, and I should have addressed this earlier. The primary revenue required in order to fund this solution is derived from commission dollars that are embedded in the individual plans. So when when we enroll a retiree, we are enrolling them on an application as their designated broker. And in effect, we then qualify for a commission from that carrier for that application. So what that does is it helps us offset the majority, if not almost all, of the cost of providing this solution on behalf of a city. And the only fees that really apply to the city are on the front end, some very minimal fees for the communication plan in order to set that up, and then the record keeping on the health reimbursement account on a go-forward basis. So it has, you know, a value opportunity not only in the premium value of the plan comparison, but there are some administrative cost efficiencies that come to the city as an employer by implementing the solution as well.
Okay, thank you. In California, there actually may be a number of cities that are in this situation, and the question is, we do not pay into Social Security. Are you able to accommodate retirees who were hired before 1986 and opted out of Medicare?
Yeah, so let me take that one. So that I refer to that type of population as a B-only population. They can enroll in Part B, but they're not eligible for Part A because they did not pay into Social Security. A few years ago, that was a problem for us. But with the advent of the Affordable Care Act and the new marketplace, the way that law is written is that if you are not eligible for Medicare, you can enroll in a marketplace plan in order to receive coverage. And so for those B-only type participants, we could present them a marketplace option to provide them coverage. And they would not have to enroll in Part B.
Okay. Two additional questions that are remaining, and if there are any other questions, please go ahead and submit them. What public agencies are using this approach? And it may be, if there are public agencies in California, you may want to highlight those, but what public agencies are using this approach?
Yeah, let me address that. So there are several California-based public agencies that are using this. Alameda County is probably one of the one in longest longevity in terms of when they implemented. The University of California is using this solution for their out-of-state retirees. There are some smaller entities as well throughout California. On a larger scale, there are several states that have moved to one exchange. Nevada was the first state to do this. Ohio is the largest state, who actually just this past fall moved all of their Medicare retiree eligible folks to this type of exchange. So we're starting to see the adoption rate within the public sector continue to grow, especially with the new GASB rules and the pressure that's being placed on them for the OPEB liability. But we're you know, the phenomenon for cities and counties to pursue this directly is becoming, I'd say in the last year to 2 years, a popular path to pursue.
Okay.
John, can you inform everybody about how many people in Ohio are covered by that move onto the One Exchange platform?
Sure. So for that campaign alone, they had approximately 160,000 Medicare eligible retirees that we managed last fall, and they actually have another 9,000 or 10,000 that will move to us this summer as well as a subsequent population. So it's one of the largest Medicare retiree populations of any employer, either private sector or public sector, that have made this type of change, and they followed the traditional path with termination of the existing group plan and offering a funding through the HRA on a go-forward basis.
And we're going to have a speaker on one of the panels at the annual conference that's been through this process, correct?
We will. Mary Kyle will be speaking at the upcoming annual conference, and she is she recently retired, but she was with the city of Phoenix, Arizona, who also went through a similar transition like this last fall for January 1st of 2016. So she came from, you know, your environment as a city employee and can talk to you about the lessons learned and going through that as well.
Okay. question, they indicate that they believe this has already been answered, but can you tell us again how this saves the city or reduces OPEB?
Certainly. So let's use an example. Let's say and let's use Medicare because it's probably the simplest example to use. If your current premium equivalent cost of your group plan is, let's say, $4,000 per year, and you're subsidizing the majority of that cost for the retiree or some portion of it. Let's make an example where you're covering $3,000 of that cost. In this model, a comparably valued plan will likely cost somewhere around $3,200 to maybe as low as $2,400 per year. So immediately off the top, the premium for comparable benefits in the individual market is less. And then if you apply the same percentage of a subsidy to that lower premium in the future model, then you as the city can basically lower your $3,000 subsidy to likely $2,000 per year, and you create a win-win outcome for both yourselves as the employer and for the retiree. Now I'm picking numbers out of the air, but those are relatively close numbers to what we typically see in current incumbent costs for a group plan and price points for the individual market. But that's why that financial analysis is so important, so that you can actually earmark those numbers and complete a true analysis with your actual data.
And John, could you speak in general terms about what kind of impact on the OPEB liability that type of analysis would result in?
Yes, thanks for reminding me that as well. So in the new design, in my example, if $2,000 is your future employer subsidy per year in an HRA, that dollar amount is a fixed dollar value, and you can design it so it has an index to it as well. So you might put a cost of living index that has it escalate on a 2 to 3% value. But that $2,000 is a fixed dollar amount that's likely lower than what your current premium equivalent cost is in your group plan, and it has less exposure to change, meaning there's no healthcare risk charges, there's no trend from the healthcare environment. It's a fixed dollar value. So the actuarial formula to calculate your OPEB liability is based on a series of assumptions that's tied to your current group plan. The group plan's cost, its forecasted trend, your participation rate, and what you subsidize. Well, in this model, you're fixing the cost to a defined value. You're eliminating a lot of the variables that provide exposure to that value to need to increase. Therefore, that translates to your calculation for liability to be less. What we typically see is that the cash savings that an employer can achieve will achieve somewhere around a 10-to-1 ratio of OPEB reduction. So if you save $100,000 in cash savings, you should save roughly $1 million in OPEB reduction. So it has a very large impact on OPEB, and the reason for that is the Medicare population, as an example, has such a long lifespan attached to it to be in the benefit. The formula for calculating that liability has a very large impact when you can reduce all those factors like trend and so forth that are causing it to climb.
Hey, and along those lines, is it possible to have a financial analysis completed at the beginning so we can decide whether or not this whole proposal makes sense for us financially before we commit? And is there a cost for that analysis, and what is it?
Okay, so number one, there is no cost for the analysis, and I would expect every one of you on the phone, if you wanted to pursue this, would evaluate that first. I would not recommend you make this decision without having done that analysis so that you can have an idea on what the future subsidy design could be at a minimum, and just make sure that the solution works. So every client that we work with, I would say, and it can't be 100%, but as close to 100% as reasonable, have gone through the evaluation process to complete this.
Okay. The final question that has been submitted is, my agency does not pay towards retiree benefits. Are the subsidies and HRA a requirement to participate in the retiree health benefit marketplace platform?
Okay, good question. The answer is no, they're not required. However, that is an element that attracts the retiree, obviously, to this solution. So if there are subsidy dollars available to them, and that's how they can access those subsidy dollars by enrolling in a plan through the marketplace, then the likelihood of them pursuing that is obviously much greater. But if you were to pursue, let's say, an example where you wanted to move the active population to the marketplace, and you do not already provide a subsidy to the retirees, we can add the retiree solution overall so that those folks, when they age in and you have new retirement events, they now have someone to go to get advice on how to enroll in their plan. So that is a combination that we could support.
Okay, that's all the questions that have been submitted. Turning it back over to John and Barry.
Well, this is Barry, and just want to say thank you very much for everybody attending. And I wanted to make you aware that there will be some future webinars on other components of the health benefits marketplace, the ACA compliance module, which we referenced a couple of times in the wellness program. There'll be announcements coming up shortly. You can go and look for more information about the health benefits marketplace in general at the web address listed below. And we encourage you to come by our booth at the annual conference. We're all going to be there. John will be there. I'll be there to answer any other questions that you might have. And there will be several sessions at the conference on topics specifically related to the health benefits marketplace. So if you do have further questions that didn't come up on the webinar, you can also go to the Health Benefits Marketplace website, and there's a Contact Us button on the top right-hand corner, and you can request additional information and on any of the topics or any of the areas that the Health Benefits Marketplace has coverage. Finally, we will be distributing a survey to those of you who participated in the webinar. Your feedback is very valuable. We're really interested to hear whether or not you thought this was a helpful session so that we can help to improve our communication about the services in the future. So again, thank you very much for participating. John and my information is now listed on the screen. You can feel to reach out to us directly. And thank you very much.